Rahul Chobe from OrthoTV. We are doing a live now in 1 or 2 minutes. I'm handing over the session to Dr. Manish. Over to you, Dr. Manish.
Thank you so much, Rahul Chobe sir. Good evening to all PhysioTV viewers. I, Dr. Manish Rai, Assistant Professor from Sancheti College of Physiotherapy, Pune, welcome you to welcome you all to today's webinar, Lumbar Pain Patients Approach, Strategy of Three-Dimensional Muscle Control Based on Stages of Motor Control, by our renowned speaker, Jakub Marzinski. Before we begin the session, I would like to introduce our panelists. We have with us Dr. Hutakshi Raiter. Who doesn't know her name? Ex-professor and HOD at College of Physiotherapy, Nair Hospital, ex-dean Allied Health, faculty at MUHS, academic council member, Senate member, chairperson and chairperson of BOS at MUHS, member of ethics committee at Nair and Somaya College of Physiotherapy. Then she has already been a PhD guide in MUHS. So around she has 43 years of clinical and as well as teaching experience. She also has been recipient of many awards like IAP Oration Award, Fellowship Award. She has conducted several workshops and presented different papers in national and international conferences. She has publications in many national and international reputed and peer-reviewed journals. She has special interest in electrophysiology, neurology, vestibular rehabilitation, and geriatric physiotherapy. We welcome you, ma'am. Thank you so much for joining us today. Our another panelist is Dr. Neeraj Athavle. He is assistant professor at Sancheti College of Physiotherapy. He is masters in orthopedic manual therapy. He has also been certified Mulligan practitioner and a certified yoga teacher. He has published various research articles in international and international journals. He has clinical experience of around 12 years with 5 years of teaching experience. I request our viewers to kindly note that your queries will be addressed at the end of the session. So you can ask the questions in the YouTube chat section. Now I request Dr. Neeraj Athavle to kindly introduce our speaker for today, who has also been my teacher. I hand it over to you, Dr. Neeraj.
Thank you, Dr. Manish. Today I am privileged to introduce our eminent speaker, Dr. Jakub Marzinski. He is a postgraduate courses in PNF assistant. He is a postgraduate in Maitland, neurophysiology, muscle balance, kinesiotherapy. He is a former Special Olympic footballer trainer, former Neurological Rehabilitation Board, Institute of Psychiatry and Neurology in Warsaw, Poland. Also, he is a IPNFA therapist since 2008, and now he has become IPNFA instructor in 2020. So congratulations, Dr. Jakub, for becoming a instructor in IPFNA. Also, he has various articles he has published in various international journals. Okay, so I welcome Dr. Jakub Marzinski, and I will hand over mic to you. I will start with your presentation.
So, thank you very much for kind words and for the invitation. First of all, I would like to hear, can you hear me? Okay. Today's, give me a second, please. So, as I said at the beginning, I'm so happy that we can meet at least virtually with all of you. But since we are many kilometers away, sometimes there can be little issues with the software. I hope we will all manage this. So it's really nice for me to be in such a nice atmosphere with you, with Manish, and with other speakers. I have had a chance and privilege to be in India in 2018 with my friend and teacher also, Fred Smedes. And this was a chance. Sorry to hesitate with my words, but I need to open the windows with your faces. So now I'm not talking to myself, but I can see you now. It's much easier. Okay. So it was a great time for me and possibility to visit in Hyderabad and India and see your culture. And I think I can say that as word is long and international, the lumbar issue is really international. And I would like to share with you the way I treat the lumbar patients. And just like a person previous to me, sorry to say, to forget the name, Dr. Now Manish can test
Dr.
my...
Neeraj. Dr. Neeraj.
Yeah, I wanted to say Neeraj. I had it at the end of my tongue. So Dr. Neeraj just mentioned this is our topic, but so I am more a practitioner. I more work with the patients than work with the university. So my approach is I would like to share mainly my practical approach to this lumbar pain problem. And it's always, my teachers always tell me, okay, Jakub, you have to have the idea how to look at this kind of patients. You have to have the idea which algorithm use. And I would like to share with you my idea of using the stages of motor control defined by Stockmeyer to assess the lumbar patients. So our patients will have butterflies in the stomach, just as you can see it, maybe more than the needles in the back. Okay, so this would be our goal. Okay, so when we think about lumbar pain, we can say that the human beings are divided into three groups. The ones that already had back pain that they already have now, and the ones that will have. And we can see some reference that really most of us are in this group. And this is the leading cause of missing and absence in in work. So you can say that you can be only specified in the lumbar pain patients, and you still will have patients to work with, because the amount of these patients is really remarkable. And what is also very important is that the majority, really the majority of the low back pain is mechanical or non-specific. And when you think about it, how many pills a day are taking low back patients, or how many surgery is undertaken for these kind of patients, then you will ask yourself why. I know one group of medical specialists that is really good in treating the mechanical and non-specific low back pain, and this group is physiotherapists. So we are really best qualified to deal with lumbar pain patients. And in Poland, fortunately, since 4 years, the patients can come directly to us. They don't need a physician referral. But I think, I don't know exactly how it is in India, but I can imagine that it's international question, an international affair, that these are the patients that are really, so they go to the physician and okay, you see there's a hernia, kaboom, there's operation. And usually we have a really nice tools to work with these patients and to help them with other than operation. Okay, so again, this is not a Bible. This is not the only way you can treat these patients. I just want to share my ideas, and I hope, excuse me, that you find them useful in some way. So first, of course, when the patient comes, you start with anamnesis. I hope everybody does it this way. And then you can hear when the pain is occurring, how often. You can ask what is the amount of pain, 0, 10, so visual analog scale or number scale. Okay, and then you can hear about really numerous points. So you can hear about the lumbar, you can hear about the pain that is radiating to the leg or even to the foot, or it stays in the buttock or in the upper thigh. You can have it on one side or on the other. It cannot only be lumbar. Maybe this is also more sacroiliac joint or the hip. But all of this region, we can say that it's really close together: the pelvis, the hip, the lumbar. And you can hear from your patients that they have problems in all of these regions. And if you are using the body chart just like me, please do not remember, you can sometimes have a transverse pain. These possibilities are really big. But please remember to make an asterisk if there is everything okay in the other parts of the body chart. Because now I know that I have checked and asked, okay, how about the head? How about the sternum? Do you have incontinence? And if I have 15 patients a day and I see a body chart like this, I am not 100% sure, have I checked, or is it painful, or I forgot? So this is just a small tip that can come in handy. Okay, so these patients that come to us, when we think about ICF model and activities that they will say they have a problem with, you will hear for sure that they have problems with walking. I would advise to ask, is it slow walking or fast walking? Because if they have problems with slow walking, excuse me, that would mean maybe this is also a hint that they may have some problems with stability issue, because if they walk fast and it's okay, then can use speed for stabilize themselves. Sitting, okay, sitting, but how long? In which position? Sit to stand, stand to sit. Quite often, again, in standing the same. How long standing is problematic? Putting the shoe on off, reaching over the head, sleeping, again, in which position? Sometimes we have a patients that are sleeping all the night in side lying left. Then no problem. Then we should not be surprised that they have a pain problem if they're 8 hours in one position. Of course, others are possible too. Okay, now if we think about the structure and function, now we have great panelists here, and I'm sure that if we ask, everybody of us, which structure and function is responsible for the problem, for the lumbar problem, then everybody would say, okay, in my opinion, muscles, majority. The other person says, okay, intervertebral discs. No, it's the soft tissues. No, it's neurodynamical or the vertebral joints or any other structure. Okay, all of them are possible. I don't want to say now which one is the most important one. You have to assess your patient for this, of course, but please have in mind that usually the discs, the soft tissues, the vertebral joints, all of this, it's, you know, this question, is it the egg or is it the chicken? So what was first? The first we have had the problem with disc, or first we have had malalignment in the posture? Yeah, so now, and with this question, usually we don't know what was first, the chicken or the egg. Here we can say that usually, of course, not always, but usually we can say that first we have a bad movement habit. First we have a bad posture, and then we can develop the disc disease, and then we can develop the muscle problem. So if we go with today's possibilities to with MRI, we go to the physician and he says that it's a problem of the disc. Of course, he wants to operate the disc because he sees the problem. But the main problem is why the disc has a problem. And the answer for this is because of the movement that is disturbed, because of the position that is disturbed. So when you look at the ICF here, it's quite obvious, it's quite obvious that everything that we do on the structure and functional level, it's very nice and it's very needed. But if we want the profound changes in the activities of our patients, we need to work on the activity level, which means that we need to move our patients, and that has to be cognitive movement that the patient is aware of. And I will show the examples of this. Okay, stages of motor control. Why are they so important, and why they make it easier for us to work with the lumbar patients? So I think most of you, I know that physiotherapists in India are very well educated. I have, I was 10 days with you guys, so I know it. So stages of motor control, you have in little finger, I'm sure. Now, mobility. What does it mean? So when we think about the lumbar patients, so mobility always happens when we initiate the movement, when we want to change the position. Okay. So if we don't have enough mobility, we are not able to change the position. And stability means that we have to stabilize the position. That's obvious. Okay, but what can we stabilize if we cannot come to this position, if we don't have mobility, if we are not mobile enough? Okay, so we need first mobility, then stability. Then if we think about activity day living, then of course we have more controlled mobility and skill situations. So one part of the body is stable, the other part of the body moves, or we have locomotion like in skill. But usually patients tell us that they have problems with skill, so let's say with walking, and we assess walking, but we forget that we sometimes need to have some steps back and check mobility and stability and controlled mobility. And then we will see why they have problems in the skill or controlled mobility. Okay, so let's start with some examples with mobility. How to assess mobility in the sagittal plane. So there is, the research shows us a lot of possibilities. You know for sure Otto-Schober test. So you start, excuse me, with the C7 spinous process. You mark 30 centimeters down. And then with flexion, it's, as far as I remember, 2 to 4 centimeters more. And with extension is 1 to 2 centimeters. And exactly in the with the lumbar part, you start with S1 level at 10 centimeters. You flex, and it should be 15. And if you extend, it should be 8 to 9. And this is a very nice test. And it has a nice research. You can always, nobody will say, hey, what kind of a test is this? So you can use it. But I would also like to, I told you, I'm a practical guy. I work a lot with patients, and I also use a lot of clinometer. And I know fingertips to floor test is a test that people say, hey, it's not only lumbar spine test, it tests the whole body possibility to the flexibility, maybe the hamstrings. Yes, but this is the activity the patients have very often a lot of problems with when reaching down, okay? And I admit, I also use it to assess the lumbar spine. It doesn't mean there are not any others also good, but I would like to talk about this one too. Okay, so I use my clinometer. I ask my patient, can you bend forward? And then I can see what is the amount of flexion. Then I assess also, then I assess also extension. And I want to emphasize that, of course, do you see my mouse? Okay, so of course I can measure the extension of the lumbar spine if I have my clinometer here, but I also think about the sternum because it shows what is the condition, what is the possibility for the thoracic spine to extend. And the thoracic and the lumbar spine in the meaning of movements are very combined together. And sometimes, so you can see, not even measuring, that our patient has problems with extension in the thoracic spine. So she compensates a little bit with the head and with the neck. So she hears that she should bend back. So she does it where she can. Sometimes you will have patients who will bend the knees, okay? Because then they are bended even more back, but there is not enough movement in the thoracic spine. It's quite visible. Okay, how can we improve the mobility in sagittal plane? Of course, we use mobilizations and manipulations. I like them a lot. Of course, we use all soft tissues techniques, nerve glides, and any other techniques that you can. But please remember that it is all structure and function level. So this is only opening the gate for the central nervous system to understand what it has to do. So now I would like to show you how to improve mobility in sagittal plane in activity level. And I want to emphasize really the importance of sensation stimulus. Everybody knows homunculus. This is taken from the SharonPriceJames.com. And she is doing this marvelous homunculuses and she sends them worldwide. So I don't want to make an advertisement, but I think I just did. But I really like this homunculus. Okay, so when you look at this homunculus, now how big is the neural representation of the trunk? Come on, it's almost none. So if you ask the patient to move with this trunk, there is no other possibility but to put your hands. Can you still hear me? Okay, so you have to, now I'm showing her because you see the way she sits. So she has a big tension in the lumbar part and not too much tension in the abdominal part. So I want my patient that she's aware of it. So I'm showing her, hey, look, I can easily go with my finger inside your belly, so there is not too much tension. And there, you see, do you see how it is tight? Yeah, I can see. Okay. So now, again, I'm really taking my sensation stimuli, I'm grabbing her trunk, and I'm showing where she should be. Now, my dear patient, yeah, I'm thinking also about the other parts of the trunk. Yeah, but then again, look what is happening. Sorry. Then again, look what is happening. I will not stop it this time, then it will not move us. Okay, sorry. But then you will see that she is moving en bloc. So she's using all the extensors chain. So she stays in the extension, and she's not able to activate the abdominals of the lumbar spine and the extensors of the thoracic spine at the same time. Of course, she's not able because it's very hard. And we are sitting all the time in this position, and we are killing our tissues with the lack of movement. Okay, so now we are back again with this point. Now we can see the movement en bloc. Okay, I cannot correct everything at the same time. This is a new movement. Okay, can you feel it now? If you sit like this, you can feel that there is less tension from the back, and you can feel the tension from the front, right? Right, good. Thank you. So then we want to, now she's aware of it. Oh, okay. Oh, it's not that just do 70 exercises I do not understand. Now she knows what we will do. And now we will use PNF, pattern pelvis rocking, and a technique, rhythmic initiation. This is a technique that teaches the movement. So, but we are still in sagittal plane, and we are still in the mobility. So, my beloved computer, please work with me. No, he will not work with me. Okay, sorry. Then I will do it like this. I'm so sorry for this. Can you see it? Now? Is it visible now?
I guess you have closed the sharing.
I cannot hear you, Manish. Is it visible?
I guess you have closed the share screen.
Sorry, wait. I'm so sorry for this. Is it now? Okay. So again, I'm showing her, this is your position. Yes. So relax. Now I will show you again. This is your position. Acknowledge this. Relax. I will show you again. This is your position. Yes. And you see, I'm really taking my time to show her this, and I'm really taking my time to relax. Now relax and go back. And she's not working against me. No, she's helping me. You can see that she's concentrated. Okay. Thank you. Help me. Good. Yes. Yes, exactly. Help me again. This is your position. If you think, and I will change my position and I will give resistance for the abdominals. So I'm from the back and my elbows are lower than her back. This allows me to avoid shearing forces in the lumbar spine. And now I try to also correct her head so she's not able to use the extensors that much in the cervical part. Yes. And we have some seconds more. And at the end, then she will be asked to do it by herself. Again, the cervical part. Okay. Yes, push into my hands. That's good. Now she sees she closed her eyes, so she's really concentrated with that movement. She's not using her mobile. She's not checking her Facebook. As she has to do it by herself. So she has to use the imagination of her new body scheme. Okay, now I will jump a little bit. Sorry for this. Okay. Sorry for these technical things. Now again here. So do you see the presentation now? Sorry for this asking. Okay. So now again, we will use quite similar, so the same, still sagittal plane, but we have a different technique. It's called replication. Okay, I'm so sorry. It turns out it is the same movie. Sorry for this. This is how it ended up when you have different movies. Yeah, but I'm getting used to it and I should be quicker. Now, so central nervous system likes repetitions without repetitions. So you can see that she's kind of sitting, but she's lying on the side, right? So again, this position is easier for her because of the gravity. I'm again with my hands really on the lumbar part, and I'm showing it. So this is the end position. This lumbar flexion close to neutral is my position I want to be in. Now, push into my hands and hold it, hold it, hold it, hold it, hold it, hold it, hold it. So I'm burning the scheme in her central nervous system now. And relaxed. I'm taking her away from it. So this is clear agonistic movement. She works only one direction. Hold it, hold it, hold it, hold it, hold it, hold it, hold it. Yes. Then relax. And then I go again. Push into my hands. Yes. And hold this position. Good. That's exactly what I want. Yes, and now show me the position that we're working in. Yes, and this is how we are teaching this movement. Now she has to find this new position. So now I can have a chance that she will use it in her activity day life because she is sorry for this. Okay. Now again, I want to try, this is what I said, to separate the thoracic extensors and at the same time the lumbar flexors. Wow, the video is working, you see it? Do you see the video? Okay, that's good. Sorry to making this sure, but okay, now. So don't come to me with the brow region. No, stay in extension, just come with the flexion down. And you see, it's so hard for her. She doesn't really know what I want. It's just not happening. So then I need to make a step back and change my position again. Now. So again, we have a wrong movie, I think. Sorry for this. But now we know I'm fast. Yes, okay. Okay, so now you see it, right? Manish, please give me a sign, thank you. So now I give her a sign, hey, this is not that I want you to touch. So hold here with extension and push towards me with the lumbar flexors. And look what will happen. The activity that was too hard, now we have a chance that is happening. And again, I have to show it. It's too hard just to describe it. I need my hands. I need my point of reference. I will say, okay, now you feel my hand on the back. So the hand of the abdominal is helping and the other one is resisting. Yes. Can you see how she's able to do it now? Look, she holds the extension. Why the difference is so visible? Because the gravity works different. Because this is the easier position for her. Now, push against my hands. Yes, exactly. This is what I want. I want extension in the thoracic and flexion in the lumbar. Good. Okay. Let's continue. Okay. Now, when you look at how she sits, okay, so of course the lumbar mobility, it's not only the question of abdominals. And you can see, and I very often mark to my patients the place where they are till which they are active with the extensors. And then you can see there is tabula rasa. There's like nothing there. So yes, and now we have a nice facilitation of the extensors. Again, I'm giving her a lot of stimuli, so she feels it. Sometimes it's painful. I don't want it to be painful, but if it is, sometimes I say, okay, sorry, but now you feel exactly which part I want you to move. Yes. And you will see that, yes, I'll say, hey, start with this part, go in front, yes. And look, now I have my hands in front. Yes, this is the movement I want. And now I have my friends in front on ilium. My elbows are low, and I say, push into my hands. Yes. Okay, now I'm winning, and push into my hands. Yes, and you can see the extensors that they come to life again. And push into my hands. Yes, exactly. So now this is my possibility. Now they can work eccentric. Now they can work concentric. Now this is my possibility to mobilize the extensors in a very specific way. Of course, now she's using a little bit, we'll see it from the closer view, and you can see that below the line, it's starting with the extensor starts to work before even the hair were not up on the skin. Yes. Okay, and I take a picture of before and after and show to my patient, and then they say, and then they know, oh, after just a couple of repetitions, there is a difference. Great, then it makes sense. Okay, we said also that the thoracic spine is so important in sagittal plane, not only in sagittal plane, for the lumbar mobility. So now we will be using the thoracic workout. So what is she doing? Look, she has a position in which the lumbar is maybe not locked, but it's quite difficult for lumbar to move. And she's using the extension of the flexion of the arms, flexion, abduction, external rotation, an extension of the thoracic spine. And with this towel, I make a fulcrum that is really nicely mobilizing the movement of the thoracic spine towards extension. But I'm asking that the abdominals are tight and the lower part stays on the wall. Okay, then we go to the frontal plane. So when we think about the frontal plane, there is a lot of possibilities to assess. I like, again, to do it with clinometer. And I just put it above the ilium. You can put it where you want, but please mark the place. And make sure that it's clear frontal plane. There's not any rotation. You can do it, of course, both sides, and you should do it, of course, both sides. Okay, how to facilitate this movement and sitting? The easiest way is usually the smartest way. So let's just shift the weight towards one side, okay? And again, I'm really close with my patient, and I'm using a lot of sensation stimuli, so she feels what she has to do. I'm a little bit mobilizing my lumbar vertebrae, just showing there this side flexion, yes. And especially at the beginning, it's really a good idea to allow her to support with her hand, with the upper limb. So yes, exactly here. So now she can use the support of the arm to even easier, to have a better possibility to shift the weight and to have the buttock up. What is very important is to shift the buttock. Otherwise, she will have a shift in the thoracic spine and not in the lumbar spine side flexion. And you can see that I'm really focused because she was doing it with some extension in the lumbar part. And I wanted more flexion, so better control of the previous sagittal plane that we were working with. And now I can resist this. Yes. Yes. Now I take the hand again. I can flip her off the chair if I want. Why not? Then the balancing reactions come in. Yes, back. Good. And now hold this nice sagittal position and then go with frontal plane side flexion of the lumbar spine. Of course, if we need, we do it on both sides, but at least we check the both sides. Okay. Yeah, now maybe I give too much resistance because you see I start with the shifting position on the other side. And it's also a really nice thing to record yourself during therapy because then you see what you're doing wrong. So I would, if I do it again, I would decrease my resistance a little bit. Good. Now we go towards the stability. So I want to show the stability in sitting with combination of pelvis and scapula patterns. Good. Now she's sitting and I'm using stabilizing reversal technique. What is essential? I want her to stay in this position. So she's not moving and my resistance, you see, sometimes she's moving, then I have to wait until she regains the stability again and look at the abdominals and look at the lumbar part. This is all working very nicely. I'm using my body, not only my hands. So body mechanism, I'm using resistance. She's aware what's going on. We're using we're treating her as a whole, not only lumbar part, but we want to combine the upper part and the lower part. And of course, when we talk about stabilization, it is not possible without rotation. So the rotation, I would even say that the rotation component is essential for stabilization. Now we'll have the example of rhythmic stabilization in sitting on neck and head. And look, this is not direct treatment. This is indirect treatment in which PNF is really strong. And so all she has to do is hold the head in one position. I could add asking her to hold a towel underneath her chin. So it would be a nice task for her, because if we have a meaningful task, it's much easier for us to perform this task. But now I'm changing the direction in different, I'm changing the resistance in different directions. Now I change it again into the stabilization reversal. So flexors, rotators, side flexors, extensors, rotators, subflexors. And always at least one of my hand is, remember about the chin, on the patient. And without touching the lumbar spine, we are able to influence the lumbar spine too. Now, another possibility of stabilizing the patient, look, again, it's not really direct. So now I'm using the lower limbs pattern, flexor and extensor patterns. Now, flexion, abduction, internal rotation, flexion, adduction, external rotation. And then I go to the feet and look what's happening with the trunk. When I say, hey, don't let me in with my fingers underneath your toes, underneath your heels. We have for free very nice stabilization of the trunk. So really indirectly, without words, we can stabilize the lumbar part. And at the end, you could see that I'm with my resistance, I'm working really at the edge, because she was a little bit moving. She should not be moving. Controlled mobility. So how can we, one more thing about stability. So how can we assess stability? So of course, it's easy when we have difficult positions. So we can think of a patient being in a plank position and stay in this position. How many minutes can you stay in a plank position? Easy. Then they collapse. We know, sorry, minutes. That would be nice. How many seconds? Then they collapse and we know, okay, 45 seconds. This is our test. But with sitting position, it's a little bit difficult to find a proper test for stability. Okay, the rules are the same. Hold this position and the period of time, but we have to make it harder. So let's say count your phone number from back to the front. Try to say a poem or hold something that is really heavy and try to really hold this position. So we have to adapt a little bit and find, for me, the easiest with stability is this: how much in the time we can hold this position. Not how much, sorry, for long. Okay, now controlled stability. When we think about the lumbar part, we want the lumbar to be stable and the legs to move. So I'm showing her, hey, my dear patient, this is a place where you have to be stable. And I'm giving her her own hand so she can stabilize and feel. And now, so let's start with flexion, extension of the hip. And you have to hold your lumbar part. Yes, please remember about good alignment of the knee. Yes, flexion, extension. Perfect, but it makes only sense when you hold this position. Yes, now try to go with your knee outside, more in abduction. Good. And look what's happening with the other limb. The lumbar part stays, okay, but the right leg also starts to move. And I want controlled mobility. So I need stability on the right leg too. So now I'm also checking, is it possible to hold this position in the open chain, which is harder, but then the right leg is completely out of control. So I need a special task. So, my dear patient, this is soap inside, liquid soap. If it pours down on you, you're all in soap. You don't want to be all in soap. So, and if I have a meaningful task, look, the right leg stays in one place. And remember about the lumbar part. So we have evidence, not the evidence, sorry, the example of controlled mobility, and it can also be a test. We can think, now you can measure, let it roll for a second, you can measure how many centimeters heel from the ischiac tuber is able to move until she loses the tension for the lumbar part. So we have a nice test for our controlled mobility on the activity level. Or we can test how many centimeters or how many degrees the knee can go outside until the lumbar part is not stable. Okay, also scooting, very nice example of controlled mobility. Right hip is stable, the left is mobile. Mobile, up and down, up and down. Okay, if we start to walk on the buttocks, it would be skill, it would be locomotion. Okay, very hard for the lumbar patients, extremely hard for the lumbar patients, but extremely useful. And also in long sitting, why not? Yes, and don't try to do it without hand support. We usually, when we move on our buttocks, we use our hands too. Okay, and I don't know how it is in India. I don't remember, but I know how it is in Poland. And a lot of my patients and colleagues, like when they work on stability, they give unstable surface to sit on or to stand on. But be very careful with this, because if the patients have problem with stabilizing themselves in stable position, for sure they will have problems with unstable position. First, we need to make sure that they are able to do it in stable position. And then as a follow-up, nice idea. So don't leave our patients. Oh, that's me. Okay. Don't leave our patients without homework. So look, now I can have the possibility to work really selectively with abdominals, and I can do it on one side and on the other side, and I have the flexion on the lumbar spine, and look, whoa, what is this? The right side mobility is much different than the left side. I was not aware of it until I've seen it from this. So I'm using, what is happening? I'm using more the side flexion than, so I should go back with my right side, activate the abdominals, and I'm using the side flexion. So it's also, if the patient see, now it's very nice. Okay, the left side works properly, and the right side, there is not enough movement possibility, but the central nervous system has the idea, and I use completely different plane. So I would have to go back and work more on sagittal plane on the right side, especially. Okay, so we're coming to the end. ICF activity level is essential in the process of profound and stable changes of a patient's posture and movement habits. Please remember, we need to move with our patients, and it has to be the movement with their brain, not ours. They cannot check Facebook or, I don't know, Snapchat, or I don't know what is now important. They have to be with us on our therapy. We cannot talk about cricket. We have to be with our lumbar spine. Remember that indirect way is very useful, and sometimes when we cannot touch the patient, especially on the lumbar part, we can use the head or the limbs to facilitate the changes in the lumbar part. Especially when working with lumbar pain patients, watch out for compensation strategies. And the last but not the least, if you decide to not allow for the compensations, show your patients different, better strategy. If you're not giving, the central nervous system does not like silence. So if you take something away, you have to give something different. Otherwise, there is no chance that the compensation strategies will be not used. So I would like to say that it's been 2 years since I was in Hyderabad. This is my friend Fred Smedes. We were together there. And this is the little couple words about us. And this is where I've met Dr. Manish. This place is taken in Golconda. Have you ever been there? This picture? If you go there, there's a lot of parking space, as you see. But we also talked about lumbar spine, and this is how we met. Okay, I hope Manish will not kill me for this. Professor Manish, sorry. I was eating mainly coconuts there. When I was there, I was in love with coconuts. And as you can see, I almost ate all of them. So I hope some of them are left still. And I still have the gifts that I got from the participants for the course. And you see, these little statues are under my Christmas tree, so they are still used. My kids and my love them. And the key holder, I also have it. I also have as a gift socks, but I will not show socks after 2 years. And I would like to thank you very much for attention. I'm really sorry for technical problems that occurred, but I hope we managed. And I guess that's it. If you have any, you can easily find me on Facebook if you have any questions to me, but I'm sure Dr. Manish and the others also want to say something, so I mute myself now.
We would like you to stay unmuted, Yakub sir. So I would ask Dr. Hutokshi ma'am and Dr. Neeraj sir, if they have any questions, they can ask. Dr. Neeraj, Dr. Hutokshi.
Thank you, Dr. Yakub. It was a great presentation with practical demonstration also. So viewers must have benefited with that. Also, you have told very nicely how to assess mobility in sagittal plane, how to improve mobility in sagittal as well as frontal plane, then also controlled stability, and how we should improvise from stable position to unstable position. So it was indeed very innovative and very thoughtful process, and we have to go actually while treating patient, we have to keep all these points in mind. So definitely it was a great talk. So one question I wanted to ask you regarding what would be the best time to start the motor control exercises? I mean, whenever there is a pain in that phase also we can start these activities, or we should wait to subside the pain and then we should start these exercises. Hello.
Can you hear us?
Yeah. Dr. Yakub.
I think yes.
Dr. Yakub, can you unmute yourself?
I guess he is unable to hear.
Hello, Dr. Yakub.
Unmute yourself. Unmute.
He's unable to hear us. I guess there is some technical issues. He'll rejoin in a second.
Okay.
So, ma'am, your thoughts about the lecture and
Yeah.
Yes. The lecture was really very interesting. Can you hear me?
Yes,
yes,
ma'am.
He did concentrate more on the lumbar spine. We feel that the lumbar spine or the low backache is the most common problem in all of us, considering that we are all bipedal and not quadrupeds. So, the lumbar mobility per se is something that has intrigued us since a long time. If you see a patient of stroke, the asymmetrical alignment in the lumbar spine, okay, and that also, if it is carried forward for a long time, can be a great problem in mobilizing and gait, and also a cause of a lot of pain. The secondary changes that take place in the muscles and in the bones and in the vertebrae following a loss of motor control. So when he spoke about motor control, we got to understand that mobility symmetry. Can you hear? Yeah, we're talking about. Can you hear us, Dr. Yakub? Can you hear?
Dr. Yakub.
Yes, now loud and
Yes.
clear.
Yeah. Okay.
Sorry for this problem.
Yeah. Keep yourself unmuted. We were saying that in India also we concentrate a lot on the mobility and stability of the lumbar spine. And being in working in neurological rehabilitation for so many years, I was referring to the patients of stroke who have asymmetry and a great loss of lumbar spine mobility. I've also seen Parkinson's patients. I've seen a Parkinson patient who was so stiff and had absolutely almost no mobility in the lumbar spine. And just a little bit of gaining of mobility is something that even got rid of his pain and gave him a lot of rotation and mobility, and even his gait improved, his gait speed improved. So, lumbar spine mobilization, especially in neurological patients, is something we've always aimed at. My question to you is Dr. Yakub, that if a patient has a lot of pain, would you start with PNF and we will start with isotonics, isometrics, or would you wait for some time? That is one. If there is a radiating pain and there is a list sometimes, the list is not necessarily because of the disc. Sometimes the list is because one side of your lumbar spine has gone into a spasm. So how would you tackle these situations where the pain is superimposed on mobility? So would you like to take a question on that?
Thank you for your question. I'm always thinking it's so nice to be in India because in 1 second I'm doctor, not master of science.
You're a
This,
doctor of your profession. That's right.
so the pain issue. Um, I will not wait. I will start right away. But I would start with indirect treatment. So usually I would
Neck, maybe.
not touch the lumbar part. Maybe work with the head. Maybe start with some easy movements, uh, especially that are pain-free. Because of course we know that if the painful spasm occurs, then it blocks the movement. Or if we have the painful joint, it blocks the movement even more. But usually we have some possibilities, excuse me, to have at least a little amount of movement that is out of pain. If not, then I would go to find the position that is pain-free. Usually the patients know these positions. Oh, okay, in this position I am able to. But I would say that I'm not leaving these patients without the approach, because if we leave them, they feel left. And if they feel left, the stress level arises, and so on and so on, and the pain level arises. So I think even now it's also a good example because of COVID situations. I have had some telephysiotherapy sessions with the patients who have had back pains, and I was able to help them just guiding their movement. And I was guiding their movement just in the direction of pain-free movement, and they were able to mobilize themselves that way. The therapy was successful. After 5 or 6 therapies, they were pain-free. Of course, now we can think, okay, was it a disc problem? I don't know, to be honest. I have had no chance to assess them. They were some kilometers away. We could not meet. But in my opinion, there is also a very important psychological aspect, that you are with your patient. You don't leave him alone. I don't know if that answers your question.
Yes, I would like to know whether you have started the technique of rhythmic initiation for the lumbar spine, especially in the early stages when there is pain, and probably a little bit of assistance, you know, that and
Okay,
a sensory
this is
stimulation and assistance that would help.
this is university discussion without the patient. Okay, but of course I will use these tools that are pain-free. So if I give resistance and there's pain, I don't do it. If I'm guiding the patient and it's helpful, then I can guide him for 30 minutes, no problem. I don't need to use the resistance is just one of the tools I can use.
Yes. What about radiating pain? There is,
Yes.
we always divide lumbar pain into uh, derangement and dysfunction. So when there is a derangement per se, maybe a disc issue, you know, so when there is a lot of instability, like for example in lysis, in diastasis, these are the areas where there is a lot of instability and a derangement. That's the time when the pain is lost. So how do we tackle those issues of the lumbar spine?
For me, the most important part is what is happening with the radiating pain. Is it going more into distal direction or not? If it's going more distal, then I stop immediately. If it's going proximal, I continue. And even if it's bigger, right? So again, if I have a radiating pain, of course I will check reflexes. I'll check the muscle strength. I'll see. Here with this lecture, I said nothing about the evaluation, but we have the possibilities of time. Not so. This is not a lumbar evaluation lecture, right? But of course, if we have a radiating pain, we have to know the level. And if I would say that our problem is the stability issue, so I work on stability, and I checked right away after my stimulation, after 10 minutes of work, after 5 minutes of work, I check my activity test. Is it going more distal or proximal? If it's more distal, I'm doing something wrong. Maybe I'm more intense, Maybe this is a time for just relief and steroid injection. I don't know. Maybe this is a time for me to consult a physician. But if the symptoms are decreasing, for me, this is information I'm doing a good job.
What do we do naturally for rotation? You said that you can do scooting or walking on the buttocks.
Yes.
So that sometimes for the elderly especially, it's very difficult because they've been stiff for a very long time. So scooting or coming in front, going behind, these are very challenging. And though you tell them to come forward, they come up as a block, in one block, where both the buttocks go up and down, in front and back. So do we have any technique where you stimulate specifically rotation?
Very good question. I was waiting for this to come. Of course, the facilitation I showed with scooting, it's for patients that are able to do it. So yes, we have possibilities for rotations. Let's say in a hook-like position, we can have the knees going to one side and to the other side. And this is a very nice rotation movement for the lumbar part. And then we can add to this just the guidance, we can add just the resistance. So the possibilities are there. And I have to say that with rotation, always is a dangerous word, but if I make a step back and check the sagittal plane and the frontal plane and improve that, usually the rotation improves too, because it consists of these two. Of course, I didn't show it. There's a lot of rotation possibilities for facilitation, but with the elderly patient and their possibilities of moving en bloc, when I was younger, I was trying to achieve this really extension here, flexion here with a 90-year-old woman, I remember. And I remember my frustration that it's not possible. So now I'm not frustrated anymore. I enjoy my life. And I'm enjoying if the patient is moving and the symptoms decrease. Okay, so it would be perfect if, in India, maybe we have yoga specialists that turn 90 and they still can do it, but majority of the citizens cannot. Well, I take what I can. If I can make some side shifts and it helps, perfect. If I have just, maybe I can move with neck and head, and it will help with some neural gliding, and it will help decrease the patients. I take what I can. If we think now with elderly patients, this is what I like with Jeff Maitland. Now, you know the concave rule. Now, which joint looks like this when you have 80 or 90 years old, right? So now we have to find the movement that gives the pain away more than this is en bloc or this is not en bloc.
That was a wonderful presentation. We would have also liked to know about the impact of foot position on the lumbar spine. Sometimes you correct your foot position so that the lumbar spine pains less. So there are a lot of about shoulder tight latissimus. If you have a PA shoulder and a lumbar spine pain, then you have a tight latissimus. So I feel the body segments of the head affect the thorax, the lumbar spine, and so on. So these are very important messages that one must know, that you have to see the alignment. In your lecture, you told us about what is the cause. Is it poor alignment that is a cause? So, everyone needs to check the alignment throughout the spine before only looking after the lumbar spine. It was a wonderful presentation. And I have noticed one thing about the lumbar spine pain, Dr. Jakub, is that when a housewife bends down to retrieve a heavy vessel, she's stuck there. These are the things when you said about activity or going into skill. The coming of the skill seems to be taking a lot of time, effort, and the skill can also aggravate the pain. A wrong skill can aggravate the pain. So
sure.
these are some of the issues which always intrigue me. I have suffered from backache a long time, and I was given a lot of diagnoses. You must be having the disc, you must be having whatever. But today I can tell you that I can do planking, I can do bridging. I am quite comfortable in that way. So
Fantastic to hear.
yes, yes. So that's what. But there was a time period when I felt I wouldn't be able to do anything at all. It was a very good presentation. I hope that everyone must have benefited from this, and we would really like to hear from you again. Thank you.
Thank you for the kind words.
Thank you, Takshi ma'am. Thank you, Dr. Yakub. It was indeed a feast of knowledge to all the viewers. I will hand over mic to Dr. Manish.
Thank you so much. Thank you so much, Neeraj sir. Thank you so much, Jakub Marzinski, for the enlightening session on the lumbar pain patients approach, strategies of three-dimensional muscle control based on stages of motor control. I am not so. It was pleasure to listen to you. Our viewers will definitely gain a lot from this webinar. So we, as he showed them pictures from our workshop, I am not so fond of calling him Yakub. We call him Kuba. So I'll say Kuba again. Thank you so much, Kuba. And also, I would like to thank our panelists, Dr. Hutakshi ma'am. That was amazing the discussion. Our viewers surely benefited from it, and the questions you were asking, that was pinpoint questions. What even I thought about it. Uh, Thank you, Dr. Neeraj sir. I would like to thank entire Physio TV team, Dr. Ashok Sham sir, Rahul Chove sir, Dr. Apurva Shimpi, and all other members of Physio TV. Lastly, a big thank you to all of our viewers who made this webinar possible and successful. Looking forward for your support in all other webinars upcoming. This is Dr. Manish Rai signing off for the day. Thank you once again. Stay safe and have a good day.
Thank
Thank
you.
you.
Thank you.